So I would like to briefly introduce about Dr. Girija Wagh. Dr. Wagh is practicing in Pune. She is a MBBS, MD, FICOG, FICS, and diploma in gynec endoscopy. Madam is professor of the gynae department at Bharati Vidyapit Medical College Hospital in Pune. Madam is senior consultant at Cloud9 and Apollo Hospitals in Pune. She is a faculty professor at OGASH, International Experts General Coordinator since 2016. Madam is chairman at the Medical Disorders in Pregnancy Committee by FOXI from 2012 to 2016. Madam is also Vice President for India chapter of Gestosis since 2014. Madam Wagh is a member of Governing Council of ICOG from 2011 to 2014. Doctor is also Joint National Secretary for FOXI in 2010, and also Assistant Coordinator for the National Eclampsia Registry since 2008. Dr. Wagh is also the member of Central Superiority Board of PCPNDT Act from 2010 to 2014, and Madam is National Mentor for Lakshya, NPO QCN, MOHFW for Government of India, and Doctor has also won the Anandibai Joshi Award for Excellence in Medical Services. So I request to take over the session to Dr. Girija Wagh. Ma'am, please.
Thank you, Mr. Parag Gujar, for that very kind introduction. And at the outset, I would like to congratulate your company, one, for bringing up this very wonderful model to our country, molecule to our country, because that's actually the need of the hour.
Thank you.
And secondly, for being awarded as the leading entrepreneur in 2021. And I think that's a very wonderful accolade to your services to finally to deal with very, very important issue. And that is the postpartum hemorrhage.
Thank you, ma'am.
So today's challenge that we are going to have today in the next about 40 to 45 minutes is going to be trying to understand around what is Carbecin, because lots is being talked about. There are a lot of trials which have come by, and now it's going to get available. Like we are having within the pandemic, a lot of questions raised about vaccines in COVID-19. Likewise, we should also look at this Carbecin. And I think this is going to be a molecule which is definitely going to help us to change our practices in hands-on. Thank you, Parag, once again for introducing me. So you can see that all the slides of mine here are having a small little sort of an icon at the back. And this icon is, I think, the picture of Mumtaz with the Taj in front of her. And who better than in India can talk about PPH, because we are the ones which are dealing with it in all aspects, whether many of our, despite our majority of women delivering in hospital settings, we still have postpartum hemorrhage hitting us. And it is now changing its pattern in the sense that we have been able to implement the active management of third shift labor to a little extent, but still we can see that many women are directly or indirectly dying of postpartum hemorrhage, because it has a prevalence of about 40%, and it accounts for up to 56% of maternal deaths in India. And one of the reasons is also that there is a whole lot of contribution now coming from hypertensive disorders of pregnancy, what we typically call as gestosis, which causes more complications and giving rise to PPH as an eventuality. So when we define postpartum hemorrhage, we always define it as a cumulative blood loss where there will be bleeding of more than or equal to 500 ml following vaginal delivery, or more than or equal to 1000 ml following C-section. It is very easy to put it into so many numbers and define. But all of my colleagues here who are attending this webinar would agree with me that it's not very easy while it's actually happening to measure what's happening. And or any amount of such a blood loss within the first 24 hours after birth, evidenced by a rise in pulse rate and falling blood pressure. And this, according to me, is most important, because we have to be on a close lookout at the time of the delivery of the woman for these two important parameters, the pulse rate and the blood pressure. And I'm going to tell you why shortly. So when you look at primary PPH, it is defined as the first within blood loss which is occurring within the first 24 hours of delivery, or secondary one, which will be after 24 hours to 12 weeks post-delivery. Now, the reason I mentioned about the pulse and the blood pressure is that we always have to be continuously in context with the chart that I have mentioned here, as you can see on the left side of the corner of the screen. And this is talking about the blood loss. How much is the blood loss if it occurs? Now, we all know that women's blood circulations are well compensated during pregnancy to be able to deal with this loss, which is going to happen at the time of the labor. And this compensation usually helps them and protects them. But if they are not well compensated, like would be in a patient of anemia, which is very common in our country, or patients of dystosis, we find that these women lose this blood very, very fast. So usually when they lose 1000 cc's of blood, 1 liter of blood, many a times the blood pressure will remain normal. They may feel a little tired, dizzy, and there will be minimal changes in their vascular or the cardiovascular parameters, the pulse and the blood pressure. And usually they are well compensated. And that is the tricky situation, because that's the iceberg phenomenon that we have to be aware of. Because quickly, if that is not dealt with, and that is so very fast, that they will land up into what we call as class 2 of the hemorrhage classification. And therefore, I always believe that this chart has to be there, because quickly, the moment they have tachycardia, tachypnea, when there is a fall in the blood pressure, that means they have already lost 20 to 25% of their blood. And that is the reason why we have to be looking at these vital parameters very, very carefully, because otherwise we would have lost the time where we could do something. So there's a good practice today and more than enough evidence which talks about measuring the shock index of the woman. And this is not the same shock index that would be in other situations when the patient is not pregnant. But in pregnancy, the shock index would be taken as 0.9. And this is because that would be the trigger for you to start resuscitation really, really vigorously, and including for probably transfusion protocols or blood component therapy to resuscitate this woman. And therefore, it's a good practice to always consider this rule of 30 and shock index. And that is 30% blood loss is taken as more than moderate loss, pulse rate increasing more than 30 beats per minute, respiratory rate more than 30 per minute, systolic blood pressure drop by 30 beats per minute, urine output less by 30, hematocrit drop more than 30%, and these will tell us. So shock index is a very dynamic thing that you can calculate by simple things. That so you look at the pulse rate, divide it by systolic blood pressure, and then if you find that it is 0.9% or more, it tells you that the patient is in shock and you require to take immediate action. Now, what is also important and that has been identified is that this shock index is also identified to be a marker of maternal mortality. So if you have a shock index, which is 0.9 or less, then the patients are more likely to succumb to hemorrhage. Not be so, the shock index is more than or equal to 1. So please remember these important things. Now, why would inversions, uterine inversions, retain tissues, invasive placentas, and coagulopathies have been identified to be the common T's, and usually coagulopathy may be already existent, prevalent, or coagulopathy would quickly set in because pregnant women have capacity of coagulopathy. These T's should not be looked at one after the other, while we should be looking at all the T's whenever a patient bleeds and quickly try to understand why is she bleeding. And especially the tone of the uterus, the most common cause of postpartum hemorrhage, being atony, results from poor contractions of the uterus after childbirth. Now, what are the risk factors of PPH? Prolonged labor, grandma para, augmented and precipitate labors, history of postpartum hemorrhage in the past, over-distended uterus like macrosomia, twins, polyhydramnios, operative delivery, chorioamnionitis, and of course, I would like to give a lot of weightage to patients who are having hypertensive disorders of pregnancy. The WHO for quite some time now has been recommending active management of first of labor for prevention of PPH. And friends, I must share with you a reality that all across the country, it is not universally practiced, one. And secondly, it is not properly practiced either. Sometimes we land up in giving certain medications which can cause issues, and I will let you know how as we go by. So what does the active management of third stage of labor include? It includes bimanual uterine massage. It includes simultaneous uterotonic agent administration, and that is very important as the baby delivers. And it also includes a controlled contraction, but that has to be done only after you have given a uterotonic and you are watched for the signs of placental separation. And I think these rules also holds true at the time of C-section, when many a times obstetrician is much in a hurry to go and put the hand inside and deliver the placenta out, which is something which should be definitely prevented. If you should allow the uterus, because already you've taken the uterus by surprise by cutting it open. And then once the baby is delivered, you can definitely allow the uterotonic given by your anesthesiologist to work on the uterus. Let it go into a good contraction. Let it start separating the placenta. And then you can gently aid it rather than briskly going in and trying to separate the placenta, which can cause more atony and more bleeding. So prophylactic administration of uterotonic agents is identified as the most important component of active management of third stage of labor and is known to reduce the incidence of PPH by whopping 50%. So cesarean deliveries, we all know, have become an epidemic in India and recorded 300% jump in the last decade for various reasons. And this is blamed on unregulated market and increased trend of women opting for it. And the incidence of PPH are higher in cesarean deliveries, about 6 to 75%, that's nearly 7%, than in a vaginal delivery. So all the more reason to be extremely careful in taking all the measures that are essential to prevent postpartum hemorrhage at the time of cesarean deliveries. Now, PPH is more likely to happen after cesarean as compared to vaginal deliveries, and approximately 36% of cesarean deliveries are complicated by postpartum hemorrhage. And therefore, it is common practice to give a uterotonic drug following delivery of the neonate during the cesarean section. And the international consensus statement on the use of uterotonic agents during C-section mentioned that uterotonic agents like oxytocin, carbetocin are recommended for routine administration immediately after delivery of the fetus during cesarean section to prevent postpartum hemorrhage. And these administration of uterotonic drugs agents are very essential during cesarean section and the third stage of labor vaginal delivery to diminish the risk of postpartum hemorrhage and improve maternal safety. Now, what are the various kinds of uterotonic drugs that we have? One is oxytocin, which you've been using for quite some time now. And now the new one is the carbetocin, which is available in our country. I've got alkaloids such as argometrin and methylargometrin, and prostaglandins and analogs such as PGE2, misoprostol, and carboprost. However, all the rest of the two are second-line agents, while first-line agents continue to be oxytocin for basic important safety issues. Now, many a times, a lot of recourse is taken to using argometrin or methylargometrin, and there have been instances where they have not been administered correctly, giving rise to challenges in the woman's health. One of the challenges being sudden cardiac arrhythmias, which can occur if an intravenous bolus of methylargometrin has been given. And also there can be an induction of a sudden seizure in a patient. Today, we may say, okay, I would not give it in patients of hypertension, but today's current reality is many women would present with new onset hypertension during delivery or even post-delivery. And these would be the women who will be at risk of developing seizures post giving argometrin. So if at all you have to give methylargometrin, it will be given only intramuscularly, only after you've already given oxytocin is not working, or if there is a definite contraindication for giving a prostaglandin E2. Like prostaglandin E2's carboprost can be contraindicated in patients who have bronchial asthma or any kind of a respiratory disorder. Even if given intramuscularly, they would be contraindicated. However, remember friends, misoprostol, which is identified to be a slow acting but an effective uterotonic drug can be given in such situations and is not contraindicated whenever there are respiratory problems. So these are the important things that you must know. And I always in my own practice use this particular information about my patient before I start taking the patient into for a vaginal delivery or for C-section. There definitely has to be a talk with your anesthesiologist and going into a mutual checklisting as to in case there's going to be a heavy bleeding at the time of delivery, what are we going to give? We are definitely helps in reducing the postpartum hemorrhage considerably. And these are the things which we require to remember. Have your own mutual checklist so that you know exactly what are we going to use if in case we experience a bleeding. Now the challenges with oxytocin is that it has a very short half-life of about 4 to 10 minutes and therefore it's short acting. The duration of action would last for 15 to 20 minutes and it must be administered as a continuous infusion to attain sustained uterotonic activity throughout the surgical procedure and immediate postpartum period. While the challenge also is because since oxytocin is being used before for maybe augmentation of labor, induction of labor, then these would usually cause desensitization of the oxytocin receptors that are already there and that can maybe make the uterus a little sort of resistant to the new acting oxytocin which we are giving at the time of delivery or cesarean section subsequently. And this has to be borne in mind. So sometimes we experience that patients who have undergone augmentation of labor usually would require a larger dose of oxytocin to be able to bring in an effective uterine contraction or retraction, or they would not act at all. So various international bodies and trials have used recommended and then the Institute of the Safe Medication Practices added IV oxytocin to the list of high alert medications, meaning minor errors that can cause significant harm to patient. While I'm speaking about this to you now, I would also want you to refer to www.foxy.org, and wherein you can go and type prevention of PPH in the search box, and you'll get a good clinical practice recommendation at the Foxy website, which is talking of prevention of postpartum hemorrhage, a GCPR, which was written by us when I was the Medical Disorders Pregnancy Committee chairperson. And that is one of the most wonderful, elaborate prevention of PPH documents, which is writing and which is also talking elaborately about the various ways in which you can use uterotonics in various situations, and especially even at the C-section. And not only that, this particular document has a valuable information on how to store the uterotonics correctly while you're using them. The Carbetocin has an advantage. It is long-acting. It's a single dose of administration, no variation in dosage regimens. It's devoid of repeated administration, ease of one-time administration. I think that's very important. Has a superior efficacy or similar efficacy as that of oxytocin, because we are very, very comfortable with oxytocin because of its extensive safety. Devoid of receptor desensitization, yes, because we'll have to continue using oxytocin for augmentation. So if you are going to have an other kind of a molecule for using for PPH management or treatment, it would be really, really nice. And it has superior side effect profile over oxytocin. So carbetocin, what is it? It's a synthetic analog of human oxytocin with some structural modifications as shown below. And you can see that structurally, both the oxytocin and the carbetocin are similar, but these modifications increase the half-life of carbetocin, thereby prolonging its pharmacological effects. Now, carbetocin has been added contained to the WHO essential medicines list of uterotonics for the prevention of excessive bleeding after childbirth. And this is a list which talks about the safest and the most effective medicines which are needed in the health system. Mind you, friends, I must tell you that such kind of safety lists, even we provide. If we do it in, you will find it on the government websites and the state government of India. Just last year, we sat across, and I was one of the experts on that particular committee, where we went and enlisted all these essential medicines which have to be available in all birthing facilities to be able to save women from preventable issues such as postpartum hemorrhage. Now, this is the screenshot of the list that I'm mentioning. And what is very important that we have to understand, that carbetocin has been recommended as the use of an effective uterotonic for the prevention of PPH during the third stage of labor and for all births universally to effectively prevent PPH. Only one of the following uterotonic should be used, and what I mentioned is oxytocin, carbetocin, misoprostol, ergometrin or methyl ergometrin, oxytocin, and ergometrin fixed dose, like what we call as syntocinon, which is of course not available in our country, but this can be used sometimes in certain situations. Like I deliver a lot of high-risk mothers. You have a patient who has a dengue and come with abruption or something like that. You may have to consider giving her a combination of medicine where her platelets are so low that you can't give her intramuscular prostaglandin. In that situation, you may consider giving oxytocin and ergometrin mixed up into an intravenous fluid and then give her. Additionally, what is very surprising to know in this essential drug list of the WHO, and that is the injectable prostaglandins, which are very commonly using, are not recommended for the prevention of PPH. Now, this may be because WHO has to cater to all kinds of facilities across the globe. And one, it may not be very easily available. Two, it is definitely expensive. And three, it has to be given in a definite controlled indication window. And that is what may be precluding it from getting into the WHO safety drug list. Now, comparing carbetocin with oxytocin is the fact that half-life of carbetocin is 40 minutes, is nearly 10-fold higher than oxytocin. That's point number one. And the duration of action is longer than IV and intramuscular oxytocin. It was found that a single intravenous bolus injection of carbetocin was at least as effective as 16 hours of continuous oxytocin infusion. And I think that's one of the biggest advantages that we can have. Secondly, it does not require a repeated administration, and there will be no dose variation, or a single dose of carbetocin is found to be effective in controlling PPH, unlike oxytocin. So carbetocin is a superior over oxytocin with respect to its pharmacokinetic parameters and single dose administration. Now, how does carbetocin work? And let's look at this wonderful video clipping. I'm sure you'll be able to hear the audio well.
A postpartum hemorrhage, or PPH, is an obstetrical emergency affecting an estimated 10% of all live births. It is the most preventable cause of maternal death. The uterine arteries pump 500 to 700 milliliters per minute into the site at which the placenta is attached to the uterus. After birth, this blood could potentially flow into the uterine cavity and be lost from circulation. In most cases of vaginal delivery, however, the myometrium contracts firmly, compressing the blood vessels and thereby reducing blood flow. A cesarean delivery can increase the risk of a PPH developing due to the insufficient contraction of the uterine musculature. Carbetocin specifically targets uterine atony. Carbetocin is administered as a single intravenous injection. After injection, carbetocin is carried rapidly to its site of action, the smooth muscle cells in the uterus. Here, it binds to oxytocin receptors. In this way, a signaling cascade is started. As a result, the smooth muscle cells of the myometrium start contracting regularly. This causes the leaking blood vessels in the uterus to be compressed and to constrict. The overall effect, the bleeding stops and uterine involution is furthered. A postpartum hemorrhage, or
So carbetocin has been studied throughout the world. Now, that is always a concern that all of us have. Has it been studied? And what is its safety profile? So it has been studied through these clinical trials. One, for management of the third stage of labor during vaginal delivery and prevention of PPH following C-section. Now let's look at certain publications that we have now and which have been analyzed. Now, this is the intravenous carbetocin versus intravenous oxytocin for preventing atonic postpartum hemorrhage, a head-on-head trial after normal vaginal delivery in high-risk singleton pregnancies, a triple-blind randomized control trial. 174 women with high-risk singleton pregnancy, and they were offered in the carbetocin group 100 mcg via slow IV over a 1 minute period, while 5 minutes slow intravenous over a 1 minute period of oxytocin was delivered. And the outcome measures were incidence of atonic PPH, postpartum hemorrhage, additional uterotonic drugs necessity, incidence of postpartum anemia, and adverse effects. And what was found was incidence of atonic PPH was 0 in carbetocin group, while it was 6.3% in oxytocin group. Postpartum blood loss was much more in the oxytocin group compared to the carbetocin group, and need of additional uterotonic drugs was found to be more in the group which received oxytocin. Postpartum anemia of hemoglobin being less than 10 was found in nearly 20% of the women who had delivered this way, and that was quite significantly more than those 10% who had with 9% nearly who had with carbetocin. So intravenous carbetocin is more effective than intravenous oxytocin for the prevention of atonic PPH among singleton pregnancies with at least one risk factor for postpartum hemorrhage. Efficacy and safety of carbetocin in comparison to oxytocin in the AMTSN followed vaginal delivery and open label randomized control trial was published in the Bangladesh Journal of OBGYN in 2016. And in these women who were about 110 in the number with a single pregnancy were compared head-on-head with oxytocin, and various things such as amount of blood loss, massive blood loss, need for additional uterotonic advance, and adverse effects were studied. And what was found that there was no differences regarding side effects between both the groups, and there was no PPH, no massive blood loss, no immediate blood transfusion necessary, or need of additional uterotonic seen in the oxytocin group, and the average blood loss 390 ml with oxytocin group. So carbetocin appears to be an effective new drug in the active and first labor in vaginal delivery and can be considered as a good alternative to oxytocin in the active management of first labor. Now, prevention of PPH following C-section was studied in an RCT comparing carbetocin, misoprostol, and oxytocin for the prevention of postpartum hemorrhage following an elective cesarean section. And it was found that in these 263 patients with a singleton pregnancy, IV carbetocin was given. Then patients in the O group were given IV oxytocin 10 international units following neonatal delivery, 20 units in 500 ml of saline was given over 4 hours, and 400 micrograms misoprostol was given sublingually in the M group. And the primary outcome which was studied was occurrence of uterine atony necessitating additional uterotonics, and the results were there was no significant difference regarding side effects between oxytocin and carbetocin, and side effects are reportedly highest in misoprostol group. We all know that misoprostol group patients will feel a lot of nausea, vomiting, and a lot of chills, and because there's sudden hypothermia after misoprostol, which can give rise to such kind of an action. And if we look at the comparison of blood loss, with carbetocin was 437 additional uterotonics was required only in 6% of the patients compared to the oxytocin group, which required 13%, and bleeding was found to be 20% in the carbetocin group compared to 34% in the oxytocin group and 47% in the misoprostol group. So we can consider using carbetocin in these situations, which will definitely reduce the blood loss, which is sort of professed during C-section, and your additional uterotonics were needed less frequently patients treated with carbetocin, and carbetocin should be an alternative compared to oxytocin and misoprostol for the prevention of atonic PPH following cesarean delivery. Now, it was also studied for comparative study between effects of carbetocin and oxytocin in isoflurane-induced uterine hypotonia in twin pregnancy patients undergoing C-section, because we are aware that many a times isoflurane is very commonly used, especially in high-risk mothers, and it has a probability of causing some sort of uterine atony if at all it's used as an anesthetic. And in these 60 twin pregnancy patients undergoing elective C-section, the various parameters were compared head-on-head with oxytocin and carbetocin. And it was found that the need of additional uterotonic drug was not felt with carbetocin, was but nearly 84% with oxytocin. And postpartum blood loss was quite less, and patients requiring blood transfusion was remarkably less and was quite more in the group which was taking carbetocin. So this study concluded that single dose of carbetocin appears to be more effective than oxytocin for several hours or uterine contractions and to prevent postpartum hemorrhage in multiple pregnancy patients undergoing elective cesarean delivery. Now, carbetocin versus sublingual misoprostol plus oxytocin infusion for prevention of PPH at CS in patients with risk factors was considered in a randomized open trial study done and published in the Arc of Gynecology Obstetrics, and these were included 380 patients, and it was found that shivering and fever were significantly higher with misoprostol plus oxytocin, and there were no significant differences regarding other side effects between the groups, such as blood loss, necessity of blood transfusion, estimated blood loss, and incidence of blood transfusion adverse reaction. So carbetocin is superior over combination of oxytocin plus misoprostol with respect to all efficacy parameters with similar side effects profile. And then what would be the studies? So if you look at certain studies where they have compared carbetocin versus oxytocin and ergometrin, where 100 micrograms of carbetocin was given intravenously to 200 women at scheduled for an elective C-section, and IV 5 units oxytocin plus 0.2 milligrams of ergometrin, which is a typical syntocinon formulation, was given. Outcome measures were studied with uterine tone, need of additional oxytocins, and blood loss. And it was found that carbetocin needed less add-on oxytocin, unlike the combination that we are talking of. And carbetocin also had less atonic postpartum hemorrhage. Now, this is something which is extremely important. So it's found to be a more potent, long-acting oxytocin with less need for other additional uterotonic drugs and less occurrence of uterine atony. And I think that is something which is very, very important. Now, carbetocin versus methylargometrin has been studied. 0.1 milligrams of carbetocin compared with 0.2 milligrams of methylargometrin in 64 women with singleton pregnancy, and various outcome measures were studied in these patients, and it was found that postpartum blood loss is much less with carbetocin. Friends, we all know that we have a lot of senior teachers who are there with us, and they keep on telling us that methylargometrin was always very effective from time immemorial. Today, we have developed a lot of reservations only for its side effects. And then this study has shown that carbetocin is not only as, but even more effective than this time testing and effective methylargometrin. And that has to be remembered in our minds. So, carbetocin is So there is also a Cochrane analysis which has been done for preventing of postpartum hemorrhage. How do we review and place carbetocin? For women who undergo C-section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. And carbetocin is associated with less blood loss in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse side effects. So carbetocin versus oxytocin after cesarean delivery, similar efficacy but reduced pain perception in women with high risk of postpartum hemorrhage also was observed as an addendum in this particular study, and post-operative pain in the day of surgery in carbetocin group was significantly lower than in oxytocin group and remained significant till the third day after C-section. And in the day of surgery and the first day after surgery, women of carbetocin group who needed analgesic drugs were significantly lower than the women of the oxytocin group. So a single carbetocin injection is efficacious and safe on the maintenance of uterine tone and on the limitation of blood losses in peri and post-operative period. In addition, carbetocin was able to reduce pain perception during post-operative days, improving quality of life for women. Utilization of carbetocin for prevention of postpartum hemorrhage after cesarean section was studied in a randomized clinical trial comparing 100 micrograms of carbetocin over a 1-minute period against 10 units of IV infusion for 2 hours. And it was found that additional uterotonic intervention was much less with carbetocin. Women requiring uterine massage was much less in carbetocin. And blood loss with minimal blood loss and less than 500 ml was also significantly improvised with carbetocin. So it's a superior alternative over oxytocin, and thanks to its long half-life on a unique injection, whereas oxytocin requires repeated injections or a perfusion of several hours with the variability of administered doses. So carbetocin versus oxytocin for prevention of PPH in patients with severe preeclampsia was studied in a double-blind randomized controlled study. And the primary outcome measures was PPH and requiring additional uterotonic secondary outcome measures and the difference in hemoglobin levels between groups. And the development of oliguria and hemodynamic status like the MAP and the heart rate after administration of the drug. And it was found that carbetocin was quite effective because there is no need for additional uterotonics or blood transfusions, need for instrumental curettage of the uterine cavity, or postpartum hemoglobin level was well maintained, and the hemoglobin difference also was well maintained, and there was no effect on oliguria. Now, carbetocin is an appropriate alternative to oxytocin for the prevention of postpartum hemorrhage in women with severe preeclampsia, considering that it appears not to have a major hemodynamic effect in women with severe preeclampsia, and that it uses a lower volume per dose than oxytocin. And it should be considered a valid option in the management of thirst of labor, because we are usually worried about a lot of fluid overload in these women, because usually the regular oxytocin for prevention of PPH or for preventing the uterine tone is necessitated to be given through a fluid vehicle, and therefore carbetocin would definitely have a better place here. So carboprost is a second-line agent in PPH, and we have compared carbetocin to carboprost in this particular slide here. While carbetocin is the first-line agent, carboprost is not recommended by the WHO in its emergency drug medications, but it is recommended by the WHO in the same list. Carboprost is associated with severe vomiting and diarrhea incidences, and there are no such severe incidences with carbetocin. Carboprost is contraindicated in asthma, while it can be used in women with asthma. If you consider the management of third stage of labor during vaginal delivery in patients with singleton pregnancy and in patients with high-risk pregnancy, and prevention of PPH following cesarean delivery in elective patients or high-risk or twin pregnancies, carbetocin has been proved to be superior over oxytocin and other uterotonic agents with respect to prevention of PPH, estimated blood loss after delivery, need of additional uterotonic agents, decrease in the hemoglobin levels, need of blood transfusion, perception of pain, and side effects profile. So in the Indian scenario, we had the champion trial, which was conducted by various workers from our own country. And this was a trial which was carried out by the WHO for carbetocin versus oxytocin across 23 centers in 10 countries, including India. And India, these were the centers that worked for this in Cuttack, and then in Karnataka, and in Maharashtra, we had the Daga Hospital in Vidarbha, and at Varanasi. So all these centers participated, and what they found was carbetocin proved to be a non-inferior to oxytocin with ease of single dose administration. And this is one of the souvenirs which came into happening, and which also mentioned an experience of one of the workers, a very dear friend, Dr. Uma Pandey from Varanasi, who mentioned that carbetocin is definitely superior over oxytocin, and this was discussed in the AISOG 2019. So this is the product profile: carbetocin composition 100 micrograms per ml, and it is in the solution already made for injection. It is indicated for the prevention of uterine atomy and excessive bleeding following delivery of the infant by cesarean section or vaginal delivery, and it must be administered after the delivery of the baby, definitely. The dose for a cesarean section is a single dose of 100 micrograms. 1 ml should be administered intravenously as a bolus injection, slowly over 1 minute after delivery of the infant. And vaginal delivery, a single dose of 100 micrograms should be administered after the delivery of the infant for the active management of thirst of labor intravenously as a bolus injection, slowly over 1 minute. So in summary, Carbetocin is superior over oxytocin with respect to prevention of postpartum hemorrhage, blood loss after delivery, need of additional uterotonic agents, deviation in hemoglobin levels, need of blood transfusion, perception of pain, and side effect profile. And it is superior over ergot alkalies to prevent PPH, blood loss after delivery, and all these things. And it also has definitely a better side effect profile than any of these drugs. So Carbetocin is superior over prostaglandin analogs, prevention of PPH, blood loss, and need for additional uterotonic drugs. However, the drawbacks of PG analogs have to be remembered as they are second-line agents, need multiple doses, not recommended by the WHO in its emergency essential drug list, associated with significant increase in the vomiting and diarrhea. So we are looking at Carbetocin now with a promise as a most efficient uterotonic drug and most awaited uterotonic, which has now arrived in India in the form of Carbecin promoted by Carbetocin Pharmaceuticals. And I think we should put our hands together to this particular company for bringing such a valuable drug to us for use. The last turn of century, we were, by the end of the century, we are blessed by prostaglandins to help us save women's lives. And I think this beginning of the century, we have now enough evidence to tell us that Carbecin can bring about this great change in our obstetric practices. So with this, I close down my deliberations. This is Dr. Girija Wagh from Pune, Maharashtra. I'm extremely privileged to deliver this talk. Thank you, Glisten, for giving me this opportunity. I would be ready to take any questions if there are any.
Good afternoon, Girija Wagh, madam.
Good afternoon. Hello, Aarti, madam.
No.
Hello, Radha.
No, I'm Dr. Madhukar Shinde from Rima Patil Medical College.
Oh, hi, Dr. Madhukar Shinde. I think it's very difficult to catch you anywhere but on this meeting. Thank you so much.
No, madam, I just wanted to congratulate you. It was a wonderful presentation and you really have a great convincing power for this particular drug. And we'll definitely use in our practice, and we'll call you if we have any kind of problem, if we need any suggestions, we'll definitely call you for that. And so all the best for the elections as well.
Thanks a ton, Madhukar. Thank you for those wishes. Thank you for being here this afternoon.
Thank you, ma'am. Our privilege.
May I ask something, ma'am?
Yes. Is Ketki?
Yeah, Ketki. Yeah. Will you recommend it as a first line in active stage of active management of third stage?
Maybe we should recommend it because it would be effective, but not unless and until. I spoke to some of the workers who took part in the WHO trial, and they found it quite effective. The challenge is its availability, and the second challenge would be its cost. But I think for saving life, 350 rupees is not a big deal.
True. Yes. Yeah, thank you so much.
Okay, are there any questions in the chat?
No, ma'am.
No, okay.
Just
hello, ma'am.
Yes, hi Sonali.
Hello, ma'am. How are you?
I'm fine. How are you, Sonali?
Yes, ma'am. Doing well.
Yeah, great.
It was really a very wonderful lecture. And actually, I had advised that MR that can we get more information before using this that valuable drug. If we are using Pitocin for induction, many times we have 5 units Pitocin running to increase the contraction of patient. So can we give both the drugs simultaneously?
See, Carbetocin has not been spoken about for augmentation of labor. No. It is only for postpartum hemorrhage.
Yes.
Not for delivery, augmentation, induction, anything.
Girija, she wanted to ask if there is
I didn't get Aarti. There is a disturbance.
If Pitocin drip is running, can we give the Carbetocin?
Yeah, we can. We should be able to give it.
Yeah.
There's no reason why we can't.
Okay. Fine, ma'am. Thank you.
Thank you.
Thank you, Girija, and best of luck.
Thank you, Aarti madam. Thank you for being here this afternoon.
Ma'am, and best of luck.
Thank you. Thank you, Sonali. Thanks again. Okay. I think there's something in the chat. I will just check if there is any question. Okay. There are people who are appreciating the talk.
Yeah.
And they liked it. Thank you so much, Dr. Sana. I think Dr. Sana is my fan follower. She follows all my webinars everywhere. Thank you for being there once again. I think I must thank both the Parags from the Carbetocin company, Parag Ramteke and Parag Gujar. Thank you so much.
Thank you, ma'am, for a wonderful presentation. And I'm thankful for all of you to attending this. And the brand is now available, ma'am. So if you have any orders, you can please give it to our MRs. It will be delivered to you.
Point in time, see, it is found to be a heat stable drug, but it's always a good practice to keep your oxytocin in the refrigerator, the same place that you'll put your vaccines. So that will be at 2 to 8 degrees centigrade. So to maintain its efficacy, it's better to place them in a proper place in your refrigerator.